And patients will sometimes come to me and say, what's the cause of my problems, doctor? What's the diagnosis? For me, and say that. Then I can give them a diagnosis. I can say this is anxiety or schizophrenia or depression.
Yeah.
Of course. That feels more real to them than sometimes to say, well, actually, if you look at the causes of those problems, if you look at the social and the biological and psychological causes of those problems, that might actually give us a better understanding of what was wrong.
The following is a conversation with Dr. Helen Crimlisk. She is a consultant psychiatrist and is the Deputy Medical Director for Health and Social Care NHS Foundation Trust. She has a clinical background in liaison psychiatry and community adult psychiatry with an interest in ADHD. She has led developments on physical health, personalisation and youth mental health in association with the Royal College of Psychiatrists. In this conversation, we will be discussing a wide range of sensitive topics such as depression, anxiety, suicide, and self-harm. Please assess if you feel this episode will be appropriate to listen to. Your well-being is our priority, and seeking support from mental health professionals is encouraged. To support our channel, please like and subscribe and check out our sponsors in the description. And now, dear friends, this is us getting a second opinion from Dr. Helen Crimlisk. Hello, Helen. It's very nice to meet you. Thank you for bringing me here today.
Thanks, Hasnain.
It's a very nice office. Have you been based here for a while?
Yes, this is the headquarters of Sheffield Health and Social Care Trust, the mental health trust that serves Sheffield. And yes, we moved into this rather nice modern building, but really has some very good facilities and brings everybody together in a way that we didn't achieve before.
Yeah, no, it was nice driving in today, to be honest. I've held something from you. So I was on upper GI surgery in my foundation training. I'm now on psychiatry liaison. So I wish I came a week later so I could maybe talk about some of those experiences, but I've done a couple of shadowing days and it is interesting. So I guess for those listening, I know you already have an interest, or that was one of your interests, is inpatient referrals. So I'm based at Royal Stoke Hospital, and then also we have Harplands, which is inpatient care, but I'm mostly based at Stoke for that job. One thing I find interesting is, even though we get referrals, one thing from speaking to the registrars and consultants in psychiatry, they prefer to treat patients who are medically fit or more so medically fit. Why is that the case then? Why do they maybe not see them early in admission, or maybe I'm getting that wrong? Why is that the case?
So I'm not a liaison psychiatrist. So at one point I did want to become one actually, and I can talk a bit more about that in a minute. But I think something you have to bear in mind is that mental health problems are very, very common. 1 in 4 of the population at any point in time. Many of us will at some point in our lives have mental health problems of some sort or other. The vast majority of mental health difficulties is managed either in families, with friends, by primary care. Of course, things can get more difficult and more severe, and that's when you begin to need more specialist services. And they range from the sort of psychological support services, which you access through primary care, through to community teams in mental health trusts, like the one that I work in. But of course, some people have physical health problems that take them into acute hospitals, and their mental health problems play out there in one way or another. They may be the cause of their admission to hospital, or they may be the consequence of their admission to hospital, or they may be a mixture of all of those things. In an average district general hospital, you'll have 1 or perhaps 2 consultant psychiatrists and a team around them of multidisciplinary other workers, social workers, nurses, support workers, etc. With the best will in the world, those psychiatrists and that team are not going to be able to meet all the mental health need of everybody within the hospital. It's just not going to work. So I suppose they have to think about prioritising what is the most important work to do. And that means thinking about what work other doctors and team members can't do.
You mean the medical or surgical team taking on maybe that slight workload of managing?
As you know, Hasnain, as medical students, you will have some experience in mental health and psychiatry. That's an absolute requirement of a medical degree. I'm not saying that you have expertise in that necessarily, but the recognition of depression, the management of anxiety, perhaps even the recognition of psychosis and certainly of dementia ought to be within the grasp of any doctor and indeed many professionals. Yeah. So help may be of course needed, especially in thinking about what needs to be done, but it's not something that you're going to, unless you have a complete shift in the numbers of psychiatrists that you're going to put in places like that, which I don't think is going to happen anytime soon. I think you're going to have to think about how to prioritise the needs of the most severely and riskiest mental illness or complex mental illness. And also think about utilising other skills. For example, as a junior doctor, you might bring a GP to ask about someone's mental health. They may have lots of information about their mental health, which has never even come into secondary mental health care before. Yeah,
that's true. I mean, part of it, on my shadowing day, they already got me calling family members. I called a mother and I called a GP to get that collateral history. And as you said, part of psychiatry care, yes, now thinking about it, is there is a bit of self-management, or the patient can manage, or the family can learn how to manage symptoms. It's not just all on the medical and psychiatry team. That's interesting. To broaden the conversation, then, you kind of talking about it. What is then the relationship between physical and mental health? As you said, let's say a patient's come in, and it could be they've developed these symptoms because of their mental health, or they have physical symptoms and then they've developed, mental health struggles. What is that relationship?
It's interesting, isn't it, the language we use, Hasnain, because we talk about these two things as if they're discrete and very different. Yeah. But we all know that health is global health, isn't it? Yeah. It's health in all senses. It's thinking about our physical and our mental health, and indeed our social health as well at some level, the sort of environment we live in, the sort of families, communities that we come from. All of these things play a really important part in thinking about somebody's general health. And yet we're very programmed to sort of separate these things out and think about people's physical and mental health.
Was that not a great question I asked then?
It's a great question, yeah. I mean, it all comes from, thinking back in the Middle Ages around dualism, what we used to call Cartesian dualism, the idea that there are two separate entities, the body and the mind. But it only needs a little bit of thought to think that that is a very oversimplistic thinking. The way the mind works at the end of the day is related to the hormones, the chemicals, the transmitters, the organs, the neurons that we have in our bodies. So there's always a biological component to what we sort of think about the functionality of the brain, and the corollary is true as well. When you have a purely physical illness, of course there are psychological consequences to that. Of course there are behavioural consequences to that. Yeah. Of course there are social consequences to that. So whilst we think about them very separately, I think we always have to challenge ourselves to avoid the sense of further separating out mind and body, because I think the real value comes from trying to integrate those two things within our thinking.
Would you say training then, or needs to change? I phrased the question as the relationship between physical and mental. Is there a separation? Is there a correlation? Is it a cultural problem maybe with medics, how they perceive physical and mental health?
I don't think it's just medics. I think it's the way we conceptualise philosophically the world that we live in. Yeah. I think it's comfortable for us to separate these things out. Yeah. And that, leads on to, thoughts about why that's so comfortable. We're quite scared of mental illness, aren't we? It's other, it's different. Although it's, I've said, very common, there's often a stigmatisation attached to mental illness, which doesn't tend to happen with physical illness. Yeah. So it's possibly convenient for us to do that, and it's not just doctors who do that, it's the whole culture that we live in. Okay. And I think that is interestingly seen differently in other cultures, I have to say. It's very much a sort of westernised medicine approach to thinking about disorder and illness. Yeah. And if you draw in concepts of cultural relevance or religion into all of this, then the world begins to be seen in quite a different way, and some cultures manage to embody that in a more holistic way than I think we probably do here.
Oh, right, okay. So you see there's a cultural difference in terms of how people perceive mental health. But the Western culture is more, they're recognizing it and seeing it. Right, okay.
And patients will sometimes come to me and say, what's the cause of my problems, doctor? What's the diagnosis? Me and say that. And I can give them a diagnosis. I can say this is anxiety or schizophrenia or depression. Yeah. Of course. That feels more real to them than sometimes to say, well, actually, if you look at the causes of those problems, if you look at the social and the biological and psychological causes of those problems, that might actually give us a better understanding of what was wrong with people. So people who develop an episode of psychosis, for example, that may be some genetic loading. There is a genetic loading for psychosis we know about. But there's also a really strong correlation between early trauma and the development of psychosis. So people who develop psychosis very frequently have a history of trauma. And there's also often a relationship between the development of psychosis and economic or environmental situations. People who are migrants are more likely to develop psychosis. People who are marginalised in society are more likely to develop psychosis. People from lower socioeconomic groups or from areas where there is tension or trauma within families or communities are more likely to develop psychosis. So if we think about it in that way, it becomes a much more rounded picture, and certainly it helps enormously when we're thinking about treatments, because the treatment of, for example, psychosis is not just antipsychotic medication. It really has to take a wider view of the biopsychosocial background of that patient to really sort of have an impact on what's going on. But that is sometimes uncomfortable to us.
To explore that,
perhaps, as doctors, to think about, well, what power do we have to influence the poverty that people live in, the discrimination that they face, the trauma that they're facing. And of course, politically, it's also challenging, isn't it? Because it gets into the whole area of how our society is organised.
I will be spending most of this conversation not talking about what, but why, because I think I understand what is this and what does that mean. But the why, I think I've touched on in med school, in the training that you've designed at Sheffield. But so the first why I'm going to ask is, I was looking through, before I came here, I was looking through referrals to the Psych Liaison team at Stoke, and common referrals were patients have developed delirium, confusion, low mood, reduced capacity, or they've developed some medically unexplained symptoms. So would you say then, is it how would you go about, understanding whether someone's developed this because of a physical cause, or these are, they have these mental health struggles, they already have these diagnoses, and then they come in with a physical disease? Or actually, do you think the hospital environment is maybe causing a lot of these symptoms? So why do people develop mental health symptoms or struggles when they come in as an inpatient? What is our relation?
So you make reference to my role as sort of lead for education at Sheffield Medical School in psychiatry. So I have a role there, that's right. And one of the things that I emphasise there is the importance of taking a good mental health history and doing a good mental health examination, sometimes called the mental state examination. And one of the things that will highlight or draw out is some of the things that you're talking about. Okay. How many of these symptoms that an individual patient has are related? How long have they been there? What was the cause of them? What were the precipitants to them? Are there things that make them better? Are they worse because they're now in hospital, for example? Maybe. Was there something traumatic about the way that their admission to hospital occurred? An emergency blue light in the middle of a shopping centre and a heart attack. Fairly traumatic. Is likely to impact on their mental health as well as their physical health. These things can get missed out when we think in a more narrow way. Obviously, if you've got somebody coming in with a heart attack, the most important thing initially is to manage that. But there might be a broader range of factors influencing the way they're presenting 3 weeks later. Perhaps with anxiety, perhaps with fear of going home, maybe with delirium because they've had concurrent infections or other complications of their heart attack. So actually, when you come in as a psychiatrist into that liaison psychiatry space, I think you've always got to go back, do another history, take a broader history than the one that was taken when they were admitted originally, to understand what was going on in life before this physical illness, what the circumstances were around the admission, and then what's happened on the ward as well. We know that wards can be really distressing places for people to be. I've been called on many occasions to see people with delirium who are being managed in a side ward in a darkened room with the curtains drawn and nurses, well-meaningly managing things, but not actually helping that person to recognise day and night individuals and understand what's going on. So the environment that we put them in can also contribute to a lot of these mental health problems as well.
In terms of then how... I'm starting psych liaison, but let's say if I was a medical surgical F1 or junior doctor, how is it best then to maybe even prevent or treat or look after or take care of your patient? I'm more talking about non-structural things and maybe more interaction-wise. And of course, it is a busy job in of itself, and you've got your registrar consultant and you've got your list of jobs to do. How should you look after that patient? What is actually achievable? What do you see as realistic?
And this is where I think sometimes the separation that we have in medical school, for example, where you do a psychiatry placement, you learn how to do these detailed assessments, can sometimes not stand you in good stead.
Because you're doing a list of things or asking a list of questions.
I suppose my answer to that would be that you can always do elements of them. We've recently actually changed the assessment process for medical students at Sheffield from what was called an observed long case, this lengthy 1 hour full history and examination, to doing things which are much shorter, saying, can you do a risk assessment in 10 minutes, or can you explore this person's psychosis in 5 minutes, or explore their cognitive state in 5 minutes, because that is much more real to the sort of things that you might be able to do as a junior doctor. But to answer your question, I think the first thing to do is to be curious, not to stick to a rigid set of questions, but to actually explore what's real for that patient. Two patients with heart attacks are very different. They may come from different backgrounds, have different anxieties, have different social circumstances they're living in.
Different worries,
And that may well inform. Just the opportunity to let people say that and for you to hear it might inform the way that you manage them on that ward. I mean, you might bring this under the banner of personalised care. Can we think about what matters to this patient and not see them purely as a diagnosis, rather than sort of and really give them some depth? And I think that can be done in a very short amount of time. People sometimes say, I haven't got time for that. I think the listening skills that we develop in medical students, and that approach of empathic responses, you can very quickly develop a rapport and have an understanding of what's important to that patient, which can inform the way that they're managed, I would hope, in a clinical ward.
Right. Okay.
And that would be preventative, wouldn't it?
Yes, it would, yeah. But even just initially, even just taking a few minutes to say, any questions, what's going on, or any concerns or any worries, even, I think, even just them unloading could help them feel that they're being treated themselves rather than a list of symptoms, disease, or a ward, or a bed number.
We're very good at asking what's the matter with the patient.
Yeah.
We're not very good at asking what matters to the patient. And those are two rather different things, and I think it's important to understand.
Yeah. And you think that's genuinely achievable for a junior doctor to be asking when they're on the ward, when they're seeing their patient, even on repetitive days? Okay. I will take that forward.
I would hope so.
Yeah. I think so, to be honest. Like, I do think about it when I'm on the wards, that, I was just on a very busy surgical job, but, when you go back and see the patients again in your own time and the rest of the day, it's made me think about maybe the sorts of questions I could ask, or the nature in which I go to that patient to see what personalised. It can be difficult because you may have a list of jobs, or especially because when you have your long list of patients and you end up thinking them as, this is my gallstones patient, this is my CBD stone patient. But of course they are different at the end of the day. Whereas in my head, I'm just thinking CBD stones awaiting ERCP or something. But
one challenge to that, Hassan, and I understand where that thinking comes from, is to think, these are my parents, my grandparents, my uncles, my aunts, people that I know.
Yeah.
They're all going to hospital having these experiences.
Yeah.
And think about how you would want them to be treated if it was them.
Yeah.
And that's not said to try and make people feel guilty, but
No.
just to remind one another that we are actually all human beings, and we do want to treat one another with respect.
Yeah.
I think sometimes there can be a fear that once you open the door to a wider range of problems, you get overwhelmed in some ways. Again, I think that comes down to training for a little bit. I think you can do very bite-sized interventions or conversations that really don't take over more time than you really have.
Right.
But the other thing to say is that sometimes you do disclose things which are quite big, and actually might be quite important in terms of thinking about the health of other people, the health of relatives, safeguarding issues, or indeed trying to sort of anticipate the complications that you might have with this patient. Is this patient likely to be someone who's going to develop confusion or depression or anxiety? Would be helpful to know, because then we can put into place earlier interventions to try and prevent things getting much worse.
Psychiatry, or being a psychiatrist, is, I think, one of the most challenging jobs, as I've seen, dealing with emotions. How did you develop an interest in psychiatry? What fascinated you about it?
Okay. So I trained at Guy's Hospital Medical School in London, and I was always interested in psychology.
Okay.
A few television programs I watched when I was younger, I thought, this sounds fascinating.
What did you watch?
Jonathan Miller, The Body in Question, and Desmond Morris about man watching, it was called.
Right.
Were two books that influenced me a lot.
I shall watch that after.
They're a bit old now, probably
right.
better things, aren't they? But it really made me, that always interested me.
Sorry, can I ask what interested you in that? So how old were you when you watched them? What interested you in those programs?
I was interested so as a teenager, I was always interested in biology and how the body worked. That always fascinated me. So the move into medicine was an obvious thing for me to move into, to go into. But it was about the interaction between the body and the mind, really, that really fascinated me, and how important it was to think about the one when thinking about the other. The way our bodies respond to illness or stress or difficulty do depend very much on our own mental attitudes towards those, and the way in which the strengths that we have and the weaknesses that we all have as individuals. So that really came out in the some of the things that I enjoyed reading and watching, particularly the work by Jonathan Miller, and also this idea that you can tell a lot by watching people. I think I quite enjoy watching people. To think about how they're interacting, why they're choosing to interact in the way they do. And to say that was particularly of interest to me at that point.
Okay. So you watched that program or programs that piqued your interest in relationships between body and mind, and then how did it go from there?
So I had the opportunity to do an integrated degree as part of my medical training, and I chose to do it in psychology. I'd really enjoyed the module that we'd had on psychology as applied to medicine, and also sociology as applied to medicine as well. So that was a great year. It was a year to do something quite different from medicine. It's also a bit of a year of growing up, I have to say, because I think medical students are very heavily timetabled, aren't they, and a bit of space to think about what's important to you. That was something I enjoyed very much. I did a lot more extracurricular things in all sorts of ways.
It is busy, medical school. It is busy, yeah.
As part of that, I was really interested in why people choose the specialties that they do as medical students, and in particular, how much that related to their own personal experience of illness. So that was my project that I did at that point. And what I found through the survey that I did of medical students is that medical students choose their specialty based on a number of different things, but of particular importance are the relationship they have with the teacher that they had in that way. So they go into a specialty because they liked that teacher.
That's true, yeah.
But also that they sometimes go into specialties because there's a particular resonance to that, because of some previous experience that they've had. I heard about medical students who wanted to go into orthopaedics because they'd broken their leg when they were 14 and really experienced that. I heard about people who wanted to do psychiatry because their mother had developed dementia at an early age, and they really thought that was relevant and that had given them an insight into that they wanted to explore. So that gave me a real interest in something which I'm still fascinated by, and that is, what we bring into our work from outside our working lives. We all have families, interests, hobbies, friends, activities, worries, and these impact the way that we work. Sometimes that's seen as being a problem, but actually it can bring enormous strength as well into the way that we work, and certainly important in terms of our values. And I think our values are really important in terms of the professionalism we bring to our work.
Quite mature thinking for a teenager to even have an interest with body and mind. Like, I don't think I had that sort of deep thoughts about emotions or that relationship.
I don't think I could have articulated all of that at the age of 23, but that was the beginning of a journey of exploring the relationship between mind and body.
Right. And your intercalated degree, was it clinical psychology? Was it just psychology? Clinical psychology. Right. Could we define these terms? What is psychiatry? What is psychology?
So I'll choose to go with the definition of psychologist and psychiatrist, because I think those are specific entities. A psychologist will have studied psychology at an undergraduate level. Then they will have worked for a period of time as assistant psychologist in a number of roles. And then they will have enrolled in a PhD as a clinical consultant psychologist, which takes about 4 years of training. It's a really hard specialty to get into, as there are many more people who study psychology than get onto that pathway, which does raise questions about what else we should be doing to support people who are interested in that into other forms of careers. A psychiatrist is a doctor, a medical doctor. They've been to medical school, they've studied orthopedics, anatomy, biochemistry, physiology, all the things that you've studied. They've then done their foundation years in the range of specialties that they've chosen, and then they've been chosen to work in psychiatry. They then go through a period of core training in psychiatry, which is usually about 3 years when they take their exams, and then they specialise further into particular areas of psychiatry as a higher trainee. They might specialise in adult psychiatry, in liaison psychiatry, in neuropsychiatry, in forensic psychiatry, in children adult psychiatry, older adult psychiatry. So you do another 4-year training as a higher trainee before you become eligible to become a consultant.
And what is unique to maybe the skill set or the role of a psychiatrist compared to maybe another specialty? Not necessarily the specialty of psychiatry and the knowledge. What would you say is different, or what is a consultant psychiatrist?
So as a consultant psychiatrist, you've gone through a range of different training experiences in a range of different subspecialties. So you will have done some time in older adults, in children's, in some of the subspecialties of psychiatry. You will also have had some grounding in reflective practice, which is really important in psychiatry, thinking about how you manage the emotions that come up. You may have taken part in what's called a Balint group, where you explore some of those things in a group with other people. You may have taken on some patients for psychotherapy under supervision. Well, you will have done, because that's a requirement of the training. You will have gained experience in emergency psychiatry, how to manage some of the emergencies that crop up in psychiatric practice. And at a higher training level, you'll also have learned a lot of the legal elements of becoming a consultant psychiatrist. What we mean by the Mental Health Act, what we understand by the Mental Health Capacity Act, how they interact, what we can do to treat patients against their will, under what circumstances, and what protections they have under the Mental Health Act. So it's an extensive training. It involves 8-9 years of rotating around different types of subspecialties and learning to manage a whole range of different mental health problems, and of course also in different settings as well. We were talking before the podcast began about the sorts of settings that psychiatrists work in. They may work, my clinical work is in a community setting, so I sit in a clinic and people come to me. But many people also work in inpatient units, where they are looking after perhaps 15 to 20 patients who are often detained under the Mental Health Act, who have really severe mental health problems and are in crisis. You may be looking after patients in what we call home treatment teams in psychiatry, which have some similarity to the virtual wards we were talking about earlier on. So these are patients who are severely ill,
Yes.
at risk of admission to hospital,
Yeah.
but nevertheless can be managed with more intensive treatment in the community.
Yes.
And those teams are generally led by psychiatrists as well.
Right. One thing I find very fascinating about psychiatrists is, I guess, how they treat patients. I think we talked about this earlier. So, you may challenge me, but sometimes I could fall into the trap that when I'm looking after a patient on the ward, I am somewhat seeing them as a list of signs and symptoms, and maybe even a bed number and a ward. But I think a reason why a lot of doctors do that is to maybe disassociate from maybe some elements of the social side, because if you were to take that all on, that could be quite a burden, could make your day quite challenging, and it could make your evening when you go home quite challenging to take that emotional burden of that are faced by patients. But I find maybe in your field of work, you can't be separate to that. You almost have to be part of that, or understand that, or that has to be part of your care or management plan after. So, and you've of course have many years of experience in psychiatry. Can I ask, how do you then balance that relationship of still actually being personal and personalizing and empathizing with that social aspect, then maybe not having it as impacted on you, whilst you still see quite a lot of patients in your day or when you work in your clinical work? How do you do that? Because I find that challenging at times.
I found that challenging when I was at your stage as well.
Yeah.
I think it's common to find that challenging, and it's not a bad thing to find it difficult.
Fine. Okay.
However, I think it is something we all need to work on.
Okay.
So within psychiatry, we pay a lot of attention to thinking about the whole person, thinking about the biopsychosocial management plan that we're going to put in place.
Yeah.
It's never enough just to do one thing. You always have to be thinking about the other things as well.
Yeah.
It also means that you need to think carefully about what the impact of patients is on your own emotional state as well.
Which it does.
Of course it does, yeah. So it's upsetting to hear distressing stories, isn't it?
Yeah.
It's upsetting as a doctor and indeed as a clinician to be shouted at by patients who disagree with what you are saying. That happens as well.
Yeah.
It's distressing to treat patients, as many of our colleagues do in older adult services, who are demented, who don't understand why they're there, or patients with learning disability who can't articulate the difficulties that they have. It's distressing and it's frustrating, and yet we need to sort of work towards managing those feelings. Yeah. The Balint group I mentioned to you earlier on, which you've got some experience of, is one mechanism by which we can think about a place to put some of those feelings, which is safe, which contains them, which helps you resolve some of those emotions, which allows you to express some of those emotions, which allows you to keep on engaging with patients as whole people, rather than distancing them and not getting involved in them at a personal level at all. So that's something which was actually initially started with in general practice, but it's been adopted by many psychiatry training schemes. Yeah. But actually, I think would be very relevant to people working in acute trusts as well.
But can I ask, I feel part of my coping mechanism is, I'm going to say, not talking about it, because then I don't go deep into it, and then I don't feel the emotions, but I still function very well. But I do see the point that if you do talk about it, then you're expressing thoughts that you already have, and probably you're sharing in Balint groups, you're sharing thoughts that everyone actually has. You're not alone. So then how do you manage that?
So these emotions are going to happen however much you try and bound yourself, I suggest.
Okay.
They in the middle of a cardiac arrest, you don't want emotions to be playing a part in what's going on. No. You don't want people talking about, this is very difficult, or I don't like the sight of blood, or, whatever else. You need to be able to think and act immediately and in the moment. And yet that whole experience may well be quite distressing to individuals.
Yeah, I've been there. It's scary.
So the opportunity to debrief some of that, again, it doesn't have to be a lengthy session, but just to be able to acknowledge the distress of that, to walk into the clinic room afterwards and say, I was so scared when that was happening. I wondered if I was doing the right thing, or I had real flashbacks of the fact that my father had a heart attack, and I wondered what it was like for him. Little things which connect you with somebody else, I think, are really valuable in trying to learn how to manage those things. Because if you don't do that, you barrier yourself off so much, you bound yourself so much, but it will come out in another way. It'll come out and eat at you from the inside, or you'll take it home to your family, or you'll snap at the next nurse that talks to you. So finding ways of expressing some of that emotion and supporting other people to do the same in a managed way, I think is a really key part of medicine, and something we should be doing not just in psychiatry but elsewhere as well.
Do Balint groups only exist if you're on a psychiatry placement or rotation, or do they exist in...
So Balint groups were developed for primary care. They've been adopted by psychiatry. There's no reason somebody can't set up one anywhere, and they do exist in other places.
Anyone can run it?
Yeah, anyone can run something like that.
Yeah.
I mean, the other thing which is run increasingly in acute trusts is something called a Schwartz round. I don't know whether you've come across that.
No, I haven't.
Quite similar in concept, really. A safe space where you can talk about the hardness of the job that you're doing. Not just for doctors, these are for all members of staff.
Yeah.
They're often facilitated by people with a degree of expertise in managing situations. Because, of course, emotions do run high. And when emotions run high, people can blame other people, they can blame themselves, they can feel intolerable emotions which they find hard to deal with. And, of course, we know that the toll of these emotions plays a really big role in doctors but also other clinicians' working lives, and leads to things like burnout, stress, people leaving the profession. So finding a space to talk about these things in some place or other, I think, is a crucial thing for all trainees. Balint groups and Schwartz rounds are two mechanisms, but there are many others.
Right.
Just finding a reflective space with a colleague, being able to express some of the difficulty that you feel with your clinical supervisor, rather than focusing on the purely academic learning.
Right.
These are good ways of trying to enable yourself, which at the end of the day protects both yourself and indeed your patients in the longer term.
I think it would be challenging for me because I have done those groups and I did find it useful. I'm not part of a group now. I would say part of my mechanism is maybe not talking about it, but then I do somewhat talk about it, whether it's friends or family, not in organised groups, but even just reflecting of cases or even just general unloading. So I do see that.
In my very first psychiatry job, that's why I say I recognise the way that you're thinking. Totally. I remember I used to go home and talk about my day at work all the time with my partner at the time. I don't think I gave away patient names, so I don't think it was a confidentiality issue. But I talked about how difficult it was. I talked about their stories. I talked about the horror of the trauma that they had experienced. That was not a sustainable situation for a relationship. That is not a healthy relationship, to need to go home and offload on your partner in that way. I'm still with the same partner. I don't do that any longer. Or we all occasionally have a moment when we need to talk about something difficult at work. But I think learning how to pace yourself in a long career within the constraints of a very stressful job and needing to have a family life and a private life as well, I think you have to try and achieve some separation there.
Another fascinating skill I find with psychiatrists is their listening skills. I can feel you listening to me, even though I'm asking you questions, in terms of how your mannerism or how you're responding or answering my questions. It seems very engaging. So I guess this is more of a general thing, not necessarily for doctors, but how do you become a good listener? I find I'm not a fantastic listener. Let's say on the wards, when a patient's there telling me they got some acute pain, and then whilst they're talking to me, in the back of my head, I'm thinking, why is this? What's the differentials? What am I going to do after? I'm going to have to speak to my registrar now. But how do you become a good listener? What are skills of a good listener?
So, really good question. And again, something which didn't necessarily come naturally to me. I think something I've learnt. And as you're talking about this, I can feel myself often wanting to jump in and wanting to say something, and slightly forcing myself to I have this concept of metaphorically sitting on my hands.
Yeah.
Because I said stop, listen, allow someone to get to the end. You can't always allow people to get to the end of their sentences. Sometimes it goes on too long, and you have to interrupt, and you have to be more forceful or directive in a conversation. But I think on the whole, you can use that time while someone is asking you a question to start thinking about what your answer is going to be, and then test out as the conversation goes on whether that's still relevant or not. So it's an active listening is a very good description, actually, because listening is not just a passive. It's not me switching off entirely and just letting you talk or a patient talk. It's actually actively thinking in my mind, what's going to be the best way of responding here? I might disagree with something and say, no, I disagree, Hasnain, with that. Or I might want to say, that's really interesting. I've picked up that, you've got that particular anxiety which only came out towards the end of the conversation. So I think active listening and knowing yourself, I suppose, is the other thing. I'm quite talkative, so I know that I have to stop myself from talking. Other people are perhaps less engaging than you describe me as being. Perhaps they need to work on those engagement skills.
What is active listening then? What does someone need to do?
Well, I think it's showing that you're listening.
Okay.
So I think it's eye contact, facial gestures, body language.
Okay.
I think that says a lot. I told you how interested I was in the idea of man watching and body language. Body language says a lot about what we're feeling, doesn't it? Am I engaged in the conversation with you? If I was sort of sitting like this and sort of looking out the window, you would be fighting harder to get my attention and wouldn't feel quite as comfortable with the way our conversation was going. So we can say a lot in the way that we sit, the way that we speak, the way that we use our faces and hands. But I was trying to sort of extend it beyond that and saying we can also use that active listening time to be thinking about what our response is. We have a range of different responses. I can respond to you in dozens of different ways for any question that or any statement that you give to me. What's going to be the most effective in that particular point in time? How are we going to get the most out of this conversation? What choices do I have about whether I'm going to disagree with you, challenge you, laugh at you, laugh with you? A whole range of things that I could do under those circumstances. So it's that active listening time is partly the engagement and partly, I think, the preparation for what you're going to say next.
Right. I think my personal issue maybe with listening is because before I even come in, I get very nervous and I think about why have I, let's say, come to see such a person? Is it to become a friend, network, or even if it's just I've just sat in a room and I just happen to speak to someone, and then whilst they're talking, I've got this back voice thinking why they're talking to me or what do I want to gain, and then I feel maybe I can somewhat lose that, that active listening, but then I'm just doing my own thing.
I think it's very important that you bring in anxiety here, actually, because all of the work that you're doing at the moment, especially as a foundation doctor, but to a degree all of us working in clinical work, is anxiety provoking. It's stressful, and that sometimes means that the normal way in which we might talk with a friend or a colleague or a family member becomes over professionalized or over managed. Of course there's a place for professional language and a professional relationship. I'm not saying there is, but sometimes I think we get caught up in forgetting that people are human and responding to them in that way. And when you come in anxious into a situation, of course a lot of your head is going to be occupied with all those things that you've been talking about. How's this going to go? Am I going to get it done in time? Are they going to like me? Is it going to work? And when that's the case, one can sometimes forget to do the niceties, to do the obvious things. The only way of managing that is to not be anxious any longer. That's easier said than done, of course. But actually, as we all know, anxiety reduces with practice, regardless of what you're talking about. The more you do it, the better you become at it. So the development of a doctor, particularly in the junior stages, is about sort of repeating things. So when you find something difficult, the best thing to do is to go and do it again, because the next time round it will be easier. And yet we know that not only in medicine but in general life, when people find things difficult, there can be a tendency for them to avoid doing that because they found it. And what do you think that does to the anxiety next time round when you're faced with having to do it? Of course, it goes really up, doesn't it?
Yeah.
These are the general principles of cognitive behavioural therapy, which I'm talking to you about now, which of course is another therapeutic approach we often use within psychiatry. But you can apply some of these things to learning as well.
I do want to talk about that, but I want to move on to a bit more, I guess, clinical psychiatry, and I want to ask questions that I feel I'm interested in. I think it is talked about a lot. What is anxiety? What is depression? I think people do understand what these terms are. But what I would find interesting is who are the people and why do people develop, let's say, anxiety or depression? From my experience, not just in this job, but just at med school, I've seen, a breadth of people, whether they're academic people to non-academic people to people who work very hard to people who are not as hardworking, or people from affluent backgrounds to working class backgrounds. I feel I see quite a range. It's more just understanding, why do people develop these? Who are the people who develop mental health struggles? I just wanted to get an understanding of that scope.
Okay.
It's a very broad question.
It's a very broad question. I'm going to start with a very broad answer.
Okay, that's fine.
Mental illness is something which is fairly uniquely human.
Okay.
If you think about other animals in the animal kingdom, maybe cats get nervous, maybe dogs get nervous, but the complexity of mental illness isn't really reflected in the animal kingdom other than in human beings, to a large degree. I mean, one can argue around the edges. So there must be something about the evolutionary development of human beings, which means that some of these emotions have a value. We talk about evolution, we think about, the way in which we have evolved to the beings that we are today. These concepts would not have survived if they hadn't had a value in our lives. Anxiety is a really good example. Across cultures, people are anxious about spiders and snakes. This is not, when was the last time I saw a poisonous spider or snake? No, I don't remember ever having seen one in the UK here. And yet I am somehow predisposed to be scared of spiders and snakes, for example.
Yeah.
There's probably a very good reason for that. Probably at some point in history, that was something which carried an evolutionary advantage.
To be afraid of dangerous things. Yeah. Okay.
We have the same sort of response to smells. We have one of the emotional responses that we can have is that of disgust. If we smell something putrid, for example, that's gone off, and you go, ugh. That's again uniquely human and probably very valuable to us.
Yeah.
And yet, all of these things can then extend into something which becomes not useful to us. So anxiety at one level is probably a helpful evolutionary concept.
Yeah.
Perhaps it's not at other levels, that sometimes that gets out of control. You could argue the same with depression, with mood. I'm not saying it's an evolutionary advantage to be depressed, but when things are going badly, it might be a good idea to retreat into a warm, cosy space where you're not talking with other people. That's not far away from some of the symptoms that we now describe as being pathological depression.
Yes.
So I think there's really interesting thoughts around why we have these symptoms, because they're universal. They don't just occur in the UK or in India. They're everywhere. They're
Yes.
universal, most of them. They've been codified, these symptoms, of course, by complex classification systems like the ICD-10, which attempts to define what we mean by a concept of depression, which is then a pathological concept. Because I've talked about these as being universal concepts. We all have mood, don't we? We all have high moods and low moods. But at what point do they become pathological? That's an interesting intellectual argument. And the classification systems which we have, such as the International Classification of Disorders, attempts to sort of codify that in some way, which is helpful. Of course, how we respond to that as a society is very interesting, because we don't always, of course, people aren't thinking about a classification system when they describe themselves as depressed.
No.
And I think this is where the issues that I talked about earlier around stigma become relevant as well. When I was growing up, you didn't talk about anxiety as a child, as an adolescent. It wasn't something that was in my... I knew the word, what have you, but I didn't talk about it. We didn't talk about it at school. Now, I don't think you go to a secondary school class in the UK and not hear people talking about their anxiety. So as a society, we're more comfortable with these concepts than we might have been in the past. And therefore they're talked about a lot more. And that's a good thing, isn't it? Because going back to what I was saying before, I think it's good to be able to acknowledge the emotions that you feel about things. On the other hand, it makes it harder to think about, well, at what point does that become abnormal or a pathology or something we need to treat? And I think that's something we struggle with a lot in society at the moment. I talked to you earlier on about 1 in 4 people having a mental health diagnosis at any point in time, and that's based on statistical, good quality research. But if you went out and asked a class of 15-year-olds at the moment how many feel anxious, and 96% of them come back and say that they're anxious, is it really going to be helpful for us to think about diagnosing them all with the disorder and treating them all with the disorder? How much of the population do we want to be disordered at any point in time? Exactly. And how much do we have to say some of this is normal? And yet, just because it's normal doesn't mean to say you can't have coping strategies for dealing with it. I've talked to you earlier on about some of the coping strategies that you might have around anxiety. If you have social anxiety, which is a big problem in our younger population at the moment, how much has the experience of COVID contributed to that, for example? People have been cooped up, they've been working from home, they've been studying from home, their social networks have been constrained as a result of that. And so one might postulate that some of the social anxiety that we're now seeing in young people may be related to that experience. Not all of it. I'm not saying that all of it's related to that. But that does begin to give us roots into thinking about how we might think at a population level of addressing some of these things or helping people to manage some of these things and telling them that actually anxiety is actually a universal emotion. We all feel it at some points. And in some places it actually is okay and probably had some evolutionary advantages to have that.
I think one of the skills is a mind reader for psychiatrists, because a lot of the things you have mentioned, I was planning to ask, but I'm glad you mentioned it because now I can go deeper or ask more about it. So what is then considered normal or the normal variant? So let's talk about anxiety. Being anxious is normal, but you having anxiety, is that normal? Or having a formal diagnosis, or let's say being depressed could be normal, but is depression normal? Or let's say concerning or requiring treatment from a clinician, where is that scope from a symptom to then a disease?
So again, I refer you back to the ICD-10, which will give you the answers to this in a formal way, because it will tell you about numbers of symptoms for how long, over what period of time, and what severity. So that's how we grade these things. I think the possibly more pragmatic view is to say, how much is it impacting on function? So I am scared of spiders. I don't like spiders. Does it cause me any problems in life? Not really. Occasionally there's a spider in the bath and I get someone else to deal with it, and that's all right. It causes me no functional impairment. I don't think I need to consider this a disorder. If I was living in the Amazon, it might be more of a problem, but I'm not, so that's okay. So I think thinking about the impact on people's lives, what it is, how it's impacting on the lives that they want to lead. And of course that's different for different people. So, what one person wants to do with their life might be very different from what another person's aims are. So I think you have to probably, in a clinical sense, think about, you would only want to treat something if it's going to have a positive impact on someone's lives. There are some people who are very happy living relatively isolated lives and don't want to do other things. What's the point in diagnosing a disorder if that's what they want to do with their lives? So functionality I think is the key for that. And again, it comes back to thing I was talking to you about earlier on of what matters to you, not
Yeah.
what the matter, but what not. I mean, it's not up to me to make a diagnosis necessarily,
Yeah.
but if somebody would find a diagnosis helpful because it leads to a treatment which would improve their lives in some way, that's a worthwhile thing to do as a clinician.
I mean, I probably read the ICD-10 criteria more than the average person, but not as much as you or someone interested in psychiatry. But I find at times when I read it, I think, I've had traits of depression at times, or traits of anxiety, or I could be a bit OCD now and again. But I find really interesting that you said these are actually normal behaviors, but then of course when they're extreme or impacting functionality or your day-to-day, then it's maybe you're thinking that this is a disease. Maybe it helps me calm me down that when I read this criteria and I've had that before. Okay, so that's interesting. How should someone then see a label then? So as you said, it's good that we're talking about mental health, and it's good that now it's a bit more accessible to treat it, to talk about it. But let's say if someone's been told, they've been thinking, I've been feeling quite anxious or stressed recently, and then you were to formally say, I think you have general anxiety disorder or social phobia or depression. How should someone perceive that? Because it's like, when you're hit with something, then it feels you're stuck with this. How should someone perceive it?
Okay, so
An individual.
One of the useful things about psychiatric diagnoses is that they're made almost entirely based on a clinical conversation.
Okay.
We don't have a test that can measure your levels of anxiety. We don't have a test that's going to tell us whether you've got depression or not. This is based on a conversation. And what that means is that it changes, and it can change. So I can say you meet a criteria for a disorder today, and you might not do in a year's time.
Yeah.
So having a diagnosis is not something which necessarily marks you out for life.
Yeah.
Having a label, as you use the term, gives both advantages and disadvantages. So the advantages are that a diagnosis is recognisable. If I say you've got depression, and that gives you something in common with the other people who've got depression, so you feel a sense of not being alone. That's a good thing. That's the same, and of course, in all, it's not limited to mental illness. The same would be true if we were talking about multiple sclerosis or Huntington's disease. So that idea of not being alone is something very powerful and helps people manage their symptoms quite often. It also opens up the opportunity for self-help as well, because people can help themselves once they are connected with people who understand those things. So the other advantages of giving a diagnosis is that because of the research that we can do, we could say something about prognosis. We could say something about what we think is going to happen in the future. So if someone was to come to me with a new psychotic episode, for example, hearing voices, having delusions, there is research which tells me, based on an exploration of their risk factors and history and the length of time that goes on, which would be able to tell me whether they were likely to go on and have another episode, whether they were likely to need antipsychotics, whether they were likely to benefit from therapy, and what their life trajectory might be like. That can be helpful on some occasions, although of course it can be difficult to hear on other occasions as well. So the advantages of classification or of diagnosis are, clarity on what we're talking about, the ability to do research. If we don't define these terms clearly, we can't do research on them. The sense of connectivity with others, and the sense of there being a prognosis or an understanding in the longitudinal terms. The disadvantages, of course, are stigma. So the stigma of mental illness we've talked about already. The being labelled with a mental health disorder is still something which some people find very difficult because people make assumptions about it. And just going back to our earlier conversation where you talked about people being diagnoses, if I talk about the schizophrenic over there or the depressive over there, these become quite pejorative terms, don't they? Because people make assumptions about what that means, which may not be based in reality. So making a diagnosis opens up opportunities, but it also brings responsibilities and challenges as well. So I think it needs to be done with care, and I think it needs to be done in conjunction with the patient, generally.
What would you recommend if an individual's listening and they've been given a diagnosis? How should they think about that? whether that's treating, learning, behaving, interacting with that new condition that they have.
If I had a diagnosis of anything, whether it be a physical or a mental health problem, I would probably start Googling or reading about things. We all know the dangers of Googling. Yes. Sometimes it can produce a whole load of rubbish sometimes, so we do need to be cautious. I would go to reputable sites. I think the National Institute for Clinical Excellence in the UK, the NICE guidelines, cover all sorts of disorders, including the whole range of mental disorders, but also physical disorders as well, and give a very balanced view on what the research shows about these disorders. NICE guidelines are continually updated based on the research output for them. So I think that's a good place to start to go. Right. That would give people an understanding of how clinicians, doctors are seeing their disorder, why they've been diagnosed in that way, but also the therapeutic or treatment options that they might have as a result of that. That's how I would approach it.
Okay, all right. I'm learning a lot today. Can I talk about your Deputy Medical Director role? Could you explain what is that role, what is the organisation, and then also, I guess, how is mental health actually delivered in the UK in terms of services, inpatient, outpatient? Could you present that picture to us?
So I work for Sheffield Health and Social Care Trust, as well as my educational role with the university.
Yes, which we will touch on.
And a mental health trust is an organisation which delivers services to a geographical population generally. We deliver mental health services, but also learning disability services and a few other services to the people of Sheffield. So that's our role here. Each foundation trust in England will have a board of directors who will oversee the running of the organisation. And one of those directors is the medical director. In fact, the medical and nursing directors are only two people on a board who have to have a clinical background. There'll also likely be a finance director, a human resources director, maybe a director of strategy, a few others. But there has to be a medical and a nursing director. And those roles carry particular responsibilities. The medical director in my trust is Mike Hunter, who I've worked with for a long time, and I work as his deputy. That means I support him in all aspects of the work that he does, but he has the overall executive responsibility on board. The portfolio of work that he's responsible for include the management of all the doctors in our organisation. We have about 150 doctors in the organisation, consultants, SAS doctors, trainees. It also involves medical education. That means that both postgraduate level, the sort of postgraduate training courses that we offer, but also at undergraduate level, the undergraduate placements into mental health trusts is overseen directly by him as well. It also includes some areas that you might not think about as being the responsibility of a medical director, and these vary a little bit from trust to trust, but broadly speaking, the medical director has responsibility for patient safety, for pharmacy, for research and development, and sometimes for quality improvement as well. So that means that the medical director oversees a wide range of people, not just doctors, who are running the organisation. So in my particular instance, we have a team running the research element of our organisation. So we have at any one time between 10 and 20 research projects going on within the organisation, looking at a whole range of different things around mental health, learning disability, which are doctors, but other clinicians are also involved in delivering. And the oversight of that and the bids for getting research money in it is under the collaborations with the university, sits under the medical director role. The pharmacy role is also important within an organisation and generally sits within the medical directorate as well. We have about 40 pharmacists within the organisation and a sort of tiered range of hierarchies about how they work. But the board is responsible for the accountability for the money that is provided for it by the health authority, or in this case, nowadays the integrated care boards who provide that money. They're required to deliver services, they're required to deliver them safely, they're required to look after their patients, and they're required to look after their staff. And that board accountability sits with the medical director. And I say, as the deputy medical director, I'm supporting that in a variety of different ways.
Right, okay. So all the deputies are clinically related, they're clinicians, as well as the medical director, they're clinical based. Is that correct?
So the deputy medical director will always be a doctor.
Always be a doctor. Right. Okay. And the scope of your roles is the delivery of services as well as staffing, training. Right. Okay then. How is mental health services then delivered in terms of what is offered inpatient, what is offered outpatient?
So most mental health trusts will have a wide suite of different commission services.
Yeah.
They will, to some degree, map onto the subspecialties of psychiatry that I talked about earlier on. So in our organisation, we have an acute and communities directorate, which delivers community mental health teams. We have 4 community adult community mental health teams and 2 older adult mental health teams in Sheffield. It will also have overall responsibility for the delivery of the psychological therapies in association with primary care, often called IAPT. Mm-hmm. Those are not delivered by doctors, they're delivered by counsellors and therapists, but they will fit under that banner. They will also have responsibility for the ward-based treatments. We have 6-7 wards in Sheffield looking after patients who are often detained under the Mental Health Act because of the severity of their mental health problems. The community services will have some specialist teams within there looking after particular groups of patients. So we have a group called the Early Intervention in Psychosis teams, for example, who look after people who are experiencing their first episode of psychosis. Because we know if we put a lot of effort into thinking about the wider elements of treatment at that point, so linking into what I was telling you before, not just thinking about psychosis, but also not just thinking about medication, but thinking about psychological, environmental treatments, we know we can reduce the rate of relapse and the rate of people having further problems. We know that people with their first episode of psychosis are at risk of losing their jobs, losing their income, losing their families, losing their relationships, losing their friends. And the interventions that we can provide at that point can mitigate against that risk and support them to not have problems in the future.
So let's say that early intervention psychosis team, did you put forward or did your team put forward that plan? So I guess, do you have that scope to introduce new services or change services based on, the culture of how mental health is changing in Sheffield?
So many of these teams are dictated by national strategy. So every mental health team within the UK will have an early intervention team. Every service within trust within the UK will have a home treatment team. Everyone will be delivering community services. Everyone will be delivering inpatient services. All of those things are written, and there are often quite tight specifications about how you do that. So you will have this sort of team, and they will do this sort of work, and we commission you to do that in that way. And commissioning means we'll give you the money if you deliver what you say you're going to deliver, what we want. So the high level things are often decided at national level. Increasingly, with the development of the integrated care boards, which are operating at sort of more regional level, they are being given a lot of power over commissioning going forward. And there are opportunities there to look at what we might call population needs. So one area might need more of a different certain service than some other ways. So the underneath that sort of national requirement to deliver a range of services will come a more local, nuanced arrangement about how they should be delivered in that particular area. So there is flexibility at that area. So we also have, for example, a perinatal service looking after women with mental health problems around the time of pregnancy and birth. And we deliver that on behalf of the whole region. So we deliver that in partnership with other local trusts. Equally, we have an eating disorders service, which is a very specialised area of mental health. And that is, again, delivered in partnership with other organisations in the area. So in both of those areas, for example, here in Sheffield, we don't have inpatient services for those disorders, but our local partner organisations do, and therefore we share those with other organisations.
What is your opinion on how mental health services are delivered in Sheffield or the UK? Do you think we're doing well, not well, covering everything, not covering? What's your opinion?
So I would start by saying we're not well resourced enough compared to acute medicine.
And acute medicine is hospital medicine?
Acute hospitals, yeah. I think we're generally, if you think about the burden on society of mental health problems, and in particular the economic burden that we have from people not being at work because of mental health problems, it's very high. And if we had better resourced services, we would be able to help more people. So the rationing that you hear me talking about when I say we can only see people with complex problems, with severe problems, where there are risky problems, and the rest have to manage within primary care, that is problematic. And if we had more resources, then we would be able to offer more specialist care to a greater number of people. And I think that would be a benefit.
Not just specialist care, but even like preventative care or dealing with mild to moderate symptoms rather than complex and severe symptoms, right?
So I definitely think we're underfunded. I think it's that's been the case for many, many years. There have been some switches to recognising the importance of mental health care in recent years, but not to a great enough degree in my particular view. You started this conversation by asking me about mental health care of patients in acute hospitals, and I don't think that's adequate. I think we could be doing a lot more. That could be done by commissioning more mental health services to deliver that, or it could be commissioned by upskilling the current workforce in an acute trust to be able to manage mental health problems better. There are lots of ways of achieving that, but undoubtedly I don't think we pay enough attention to it.
Why do you think there is that underfunding? Is it because non-acute medicine is not funded very well, or do you think there still is? We did talk about mental health stigma, maybe at an individual level. Do you think there's a mental health stigma on a political level or policy level, for managing? You think so?
Absolutely, I do, yes. And one of the other organisations I'm involved in working with is the Royal College of Psychiatrists, so the professional body for psychiatrists, and they campaign on a regular basis on policy and on what we might call fair access to care, and it is unacceptable, the waiting lists that we have at the moment for mental health treatments of a variety of different situations. That, of course, is also a problem in acute medicine. I don't dispute that, but I think mental health does not get a fair share of the funding that's available.
You say that's specific for mental health. It's not, or do you think it's more of a general for acute medicine?
Well, you could also, if you wanted to broaden it out, you could say as a country we spend less on healthcare than most of our European neighbours do as a proportion of GDP. Yeah. Having said that, I know that other countries are struggling with that budget as well. Yeah. And there are many ways of delivering healthcare. We have in the UK, we have the National Health Service, which is on the whole revered and admired throughout the world as giving access to health at the point of need without cost. Yeah. That is not the case if you go to other countries. So there's enormous value to that. But of course, the NHS has been battered a bit over the last decade or so. And part of the reason for that is I think there is inadequate funding going into the whole system. The challenge is to find a way of bringing in additional funding, but also transforming the way we deliver care. There's no doubt that the way we deliver care with our hospital-based treatments is probably not sustainable in the longer term, and we need to be thinking about models that think about prevention of health problems, that think about early intervention, that sort of secondary prevention, if you like, once people have started to get a problem. How can we reverse that? We're seeing good evidence, for example, that type 2 diabetes can be reversed by good diet, and yet we're not spending enough money on promoting that, and the burden of type 2 diabetes across the country is rapidly getting out of control, but we're not putting the focus in at the earlier stage of the prevention element of the disorder. We're still putting Burger Kings next to school gates and not talking about the public health element of this. So lots of things that we could be doing as a primary and secondary prevention level, but also lots of things we can think about doing in terms of our service delivery. We've got major waiting lists in the country at the moment, but many people are on waiting lists for lots of different problems, and yet they're all being dealt with separately. When we bring somebody in for their hip replacement, why aren't we thinking about getting them their diabetes checkup at the same time?
That is true. Yeah.
Just a simple example, but we need to be thinking about integrating the care. And that goes back to what I was talking about earlier on about seeing the patient as a whole person, not as a collection of symptoms and disorders.
But whilst maybe I'm taught that at med school, we have a general election coming up. Do you think anyone is properly talking about this, talking about preventative medicine or the biopsychosocial aspect of treating symptoms? Is this being done enough?
I think it's been talked about, but whether, and I'm not going to give you my own political views on this, but I think it's being talked about by everyone, and I think there is a general recognition that we cannot keep going in the way we are doing. The NHS was, devised 75 years ago for a population that had a life expectancy of 65. That's no longer the case. It wasn't built or designed with the sort of polymorbidity that we see in many of our older people these days. My father is 86, I think, and has a number of different disorders, and is now managed by a frailty unit. He doesn't like the term very much, but the service they provide is excellent. So when he goes in with one problem, immediately they do a check on everything else to see what else is going on. They anticipate problems, not just respond to them. If we could adopt something like that to a number of other areas of care, and of course it's good economically, it's good medically, and it's also good from the point of view of patient experience. My father doesn't want to be going to 15 different outpatient appointments for the 15 different medical problems he has. He would like someone to deal with the whole of him, preferably quickly and without getting into hospital.
Whilst there, and of course preventing other things from happening as well. I do see that. I want to move on to, I guess, more societal aspects of mental health. So we've seen an increase in mental health diagnoses in the last decade, let's say. So a statistic I found on the WHO website was there's a 25% increase in the prevalence of anxiety and depression worldwide. The WHO Director General said, "The information we have now about the impact of the COVID-19 on the world's mental health is just the tip of the iceberg. This is a wake-up call to all countries to pay more attention to mental health and do a better job of supporting their population's mental health." And if I may add on another aspect, which is, I think you mentioned earlier, it is good that we are talking about mental health, breaking down the stigma. This is my own personal curiosity. Why is there an increase in the prevalence of anxiety, depression, other mental health struggles? Is it because we're talking about it more? These services are getting more accessible, so therefore people are getting appropriately treated and identified? Or is it actually life is getting tougher for people, there are more challenges, and there's actually, I'm going to say, an increase in prevalence from not unknown causes? Why is that?
I wish there was a simple answer to that, because I don't think there is, and I think it's a combination of the things that you describe. Okay. I think we are seeing better recognition of mental illness. We are seeing, at least in the Western world, more acceptance of mental health struggles and people seeking help. I think that's a good thing. We are in many countries seeing increasing access to psychological therapies. In the UK, we're increasing the amount of psychologically based approaches that we take to people's mental health problems. That may be happening in a therapeutic way, such as formal counselling or therapy, but it's also happening in a non-therapeutic way. I don't mean that it's not therapeutic, I mean it's not a clinical setting. When we think about how we talk to children, for example, about dealing with stress, that's not a clinical interaction, but nevertheless it may be preparing them and helping support them.
Because you said these are normal things, to be anxious, to be low.
But of course, if you've got a lot of normal anxiety, you're more likely to sort of tip over into having anxiety that causes a problem at some point. I think COVID has undoubtedly highlighted how important meaningful occupation, good quality communities and relationships, the social benefit that we get from work and study has been really highlighted by what's happened over the period of COVID, when many people haven't been able to access that. We think about education as being about academic excellence, but actually it's socialization. It's developing social networks, social support mechanisms. It's growing up, isn't it? It's more than just the facts.
Yeah.
And yet, for many young people, that's not been available for a period of time over the last 5 years. Likewise, for older people, I've got another elderly relative who was not able to go out much during the COVID times for obvious reasons. And we didn't quite realise how important she lives on her own, how important the social connection was that she got from going shopping every day or walking to the post office or doing something else. These were absolutely crucial to her well-being. And when they ceased to be able to happen, we really noticed how much more she struggled, both with anxiety, with mood, but also with her general confidence in living. She's elderly, and it certainly impacted on how well she was able to function. So some of these things which we possibly took for granted or didn't really recognise were clearly really important to us at all stages. I've given the example of young and old, but I'm sure you could find examples in other groups of people as well. So, what does that mean? That means that we should play, now that we're in a post-COVID world, well, not quite, but, heading that way. Yeah. We should think about how we value these things, how we make use of those things. We've moved to an area where many people work from home. There are lots of advantages to working from home, but there may be disadvantages as well. Or if you are working from home, 40 hours a week, what are you doing to have the sort of meaningful social contacts that might be important to your well-being in long term at other parts of your life? So it's about balancing those things. Exercise is another thing that we really lost during COVID, wasn't we? We didn't recognise how many steps you were taking just wandering around a building during the day or a ward during the day. Yeah. And when you weren't doing that and suddenly found yourself sitting at home, you found out that you're actually doing an awful lot for your steps, and that's not actually good for you. Yeah. Now, we can adapt. We're uniquely adaptable as a human race, but we need to think about how we adapt to balance up the sort of things that we know are good for us and make us well. And the things that, there's this concept of 5 ways to well-being. I think you've come across it, which talks about what are the things that keep us well in society. Well, it's meaningful activity, a feeling that we're useful, that we really feel that's important. It's exercise. It's supporting other people. It's learning other things. And all of these things contribute enormously to keeping us well. So thinking about that prevention element as well, whether it's physical or mental health, we should be paying more attention to that as a society, in the way we organise society, in the way we organise schools, colleges, workplaces, to make sure that we are not causing more illness than we need to.
Are you concerned the increase in prevalence of these mental health struggles, or do you feel this is a societal change?
No, I am concerned about it, because I think, as well as the positive element of increasing recognition and reduced stigma, there is a negative element to it as well, which is that we are living increasingly unhealthy lives in unhealthy communities, in unhealthy societies. So this sort of really goes into the area of public health, but we know that many people are experiencing trauma in their life in one way or another through the lives that they're experiencing. We know many more people are living in poverty these days, which doesn't give them access to things that they need to work well. We know that societies where there is a greater polarisation between rich and poor are generally unhealthier societies. They're not good to live in, because you're always looking around your corner at the people who are doing much better than you. So I think it does really give us pause to think about how we live as a society, and what we can do to influence that. Poverty, I think, is a major problem in this country, but also globally, of course, because it reduces access to doing the things that would otherwise keep people well, whether that's eating fruit and vegetables, or getting out into a green space to do some exercise, or finding a community which will accept you and give you the sort of social sustenance that we all need.
A brief question, I think I forgot it earlier, but I definitely wanted to ask it is suicide and self-harm. I think this is maybe something that I'm interested to know, because maybe I've not really felt that before, so I'm interested to hear your insights on that. Could you maybe explain what is going on maybe in someone's mind when they do develop those thoughts? Because I think most people probably not experience those things. But they may have experienced depression or anxiety and stuff. So what's going on in someone's mind when they develop these thoughts, or maybe feel like acting upon them?
I think we should separate them out, the two ideas, because I think they often, although they're related, of course, I think they're very different ends of the spectrum. So people who harm themselves, when you talk to them about it and ask them why they're doing that, they're not usually suicidal. They're usually harming themselves because of some intolerable or impossible to manage psychological distress or pain that they're feeling. And those feelings are really hard to live with, because you're feeling all the time that you are not valued, feeling rejected, being denigrated, being discriminated against, all sorts of things which people feel. And when those feelings are unbearable, people often prefer physical pain to mental pain. So people might cut themselves or scratch themselves or do other things that cause physical pain and somehow distracts them from that mental pain that they're feeling. That's often when you talk to people, that's often what they say they're doing.
As a form of distraction? Distraction,
but also somehow the experience of having physical pain can take the mental pain away. It sort of moves it into a lesser level. It makes it less dominant in some way. Now, I'm not advocating this as a good way of managing intolerable stress, but I'm saying that sometimes people resort to this because they can't think of other ways out of that. And when I'm working clinically with somebody who engages in self-harm behaviour, then I'll often talk to them about what else they could think about which would be less self-destructive, that might help them manage that pain. Now, that might be finding an outlet for talking about these things. It might be distraction in a different way. Banging a pillow against a wall is a perfectly reasonable way of, getting some emotion out if that helps you. But so might be going for a run and getting the adrenaline run that you get out of going for a run, or going for a swim, or just finding yourself in nature, or talking to a friend, or a whole range of things. So it's about exploring what the other options are for that person at that time. And we do a lot of work in trying to support people to find alternatives, because most people don't want to engage in this behaviour. If they can find another way of managing their emotions, they prefer to have. I think when we talk about suicide, that's when people have got to such depths of despair that they can't think of anything else to do other than end their life. That's obviously an absolutely desperate situation for people to be in. When people are suicidal, it is often down that closing down of options that they see. They really feel that there are no options left in life. And the words that's often used is hopeless. But also I think feeling humiliated is another important idea that often comes as often you find in people who are really at the depths of despair and don't know what to do about that. They feel that there are no further options for them to go to in life. There are no one to seek solace from, no one who's going to be able to help them. And those can be quite strongly held beliefs at that time. When you're talking with people who are suicidal, it can be useful, and of course this is a routine part of a psychiatrist's job. It is of course quite distressing. It does need training, it does need support, it does need those relapses, releases that we talked about earlier on that might come through supervision or other sort of support mechanisms. But the skill is trying to help people think about what those other options might be, what that sort of little bit of hope might be that might help them work through the difficult period that they're finding themselves in. And there's the clinical job of assessing the risk in suicide, which might be an important part of an assessment, for example, to think about what the risks are. Because, of course, there are options that we have under the Mental Health Act to detain people who are at high risk of taking their own life. But it's also to try and work with them to try and find those areas of hope. Perhaps, there might be an option to get a new house, to leave this abusive partner, to get out of this intolerable situation, to find a way out of the financial chaos that you've got yourself into. And if you can just give people stepping stones towards that, then you can help them get over that feeling of there being no choices other than suicide.
I think the only relatable feeling that I've had is maybe at times I've felt like escapism, where lots of pressures on me, or expectations, or deadlines, or workload, or I can't see when the next day off or break is. And then at most I would feel like escapism of I just want to drop everything for a day or two. I think that's when I was reading before I came here today, trying to think how could I empathize or sympathize with suicide, self-harm. I think that's the closest I've never had those thoughts, but that's the closest I've felt to it. And I imagine maybe with suicide, escapism is maybe a way that they see out of the struggles that they're going on. And that's interesting you say, providing hope.
So providing hope is important. Escaping is a very reasonable response to a stressful situation. I understand why that's the case.
Yeah.
On the other hand, it can sometimes have connotations of not dealing with the situation.
Yeah.
So sometimes, if you can just escape and get out of it for a while and come back and find that things are better, that's great, isn't it? But of course, if you come back and find things are worse, then escapism isn't really delivering on its promise. And people mean different things by escapism. If it's switching off and listening to a piece of music, or getting engrossed in a film, or going for a walk in the countryside, or just putting all your books down for 2 weeks and not talking to anyone and going on holiday. All of those things are really sensible things to do. I don't disagree with any of those. But of course, sometimes people resort to other things to escape, don't they? They resort to alcohol or drugs, or they resort to behaviours which are going to accentuate their problems rather than solve them. You see people who are getting into debt, for example, just getting into more debt, or gambling. So escapism, you need to think about whether or not that's going to be truly beneficial in the long term, what the impact is beyond when you return to reality, and whether you're going to have done any more damage by the time you do.
I'm going to ask closing questions. You are the psychiatry undergraduate lead at Sheffield Medical School. Incoming here, here's an interesting thing. I spend plenty of time at the Keele Medical School Library at Stoke Hospital, and I see a lot of posters about talking about healthcare professional students and monitoring their mental health and looking into it. Healthcare professional students are more likely to suffer from mental health compared to their peers in other courses. Maybe we could broaden that out to professionals as well, as in doctors and nurses. Why is that the case then for healthcare professional jobs, that we are more likely to suffer compared to our peers or friends in other career paths?
So, teasing that out, I think there are several reasons that might be. I think it's an inherently stressful job, undoubtedly. We're dealing with people who are at really difficult times in their lives, aren't they? We're dealing with the things that mark out the beginnings and the ends of lives, the traumas that people experience. That's our bread and butter. So things that might only happen to an individual person 2 or 3 times in their lives, you're dealing with it on a day-by-day basis. That is very stressful. So I think that it goes with the territory to say that might lead to people talking about anxiety, depression, stress in a different way. On the positive side, we are more likely to be able to express those things, and we are more likely, I put it to you, to be able to seek out help. We have, theoretically at least, the knowledge and the understanding to know that mental health problems are not a weakness, that they are treatable, that there are services out there for them. There are some very specific services which are on offer to people from the medical profession or nursing professions, for example, because we recognise that they are at greater risk. But I think, going back to the beginning of our conversation, I think that's what it makes it even more important to pay attention to the emotions that come with the job, that are going to happen. We can't expect to train a medical student to become a foundation doctor without experiencing distressing and upsetting experiences. Yes. You wouldn't be doing the job unless you were doing that. That is the job. And therefore it's also incumbent on us, I think, to think about what the support mechanisms are you need to build in internally as an individual, but also within a training scheme, for example, and also within an organisation to help support you, particularly with those difficult experiences.
And when looking, I found that out of all the specialties in medicine, psychiatrists are most likely to actually go and seek help, even though they are more likely to suffer from mental health. So can I ask, how do you manage your mental health?
Well, I'm so pleased you found that statistic. I consider that to be a real success story if they do that. I manage my mental health. I feel very lucky in my life. I have I had loving parents. I had a good upbringing. I had good relationships. I've got good family. I have 2 lovely children. I've got a new kitten. These are things that bring me joy and pleasure and relief from the stress of the job. I have, of course, had difficult times. We all do. A patient of mine killed himself 2 weeks ago. I didn't sleep for 2 days thinking about that. That's normal as well, I think, and I've sought help and sought some support to try and manage those things in work. I think it's really important to have fulfilling lives outside work. Medicine is a vocation. It does tend to dominate our identity, and yet I think it's really important to give that up at times and be non-medical, normal, other in our social lives. So I have lots of hobbies. I have lots of friends. I have lots of things that I do which don't involve socialising with doctors. And I think that's one of the things that keeps me healthy.
Okay. If you have a loved one who is suffering from mental health, you said part of the care is actually the family delivering the care. So if you have a loved one who's, let's say, suffering from mental health symptoms or has a diagnosis, what would you recommend those listening for the family or friend to do for their family and friend?
Yeah, I think it's really important to recognise the importance of carers and the burden on carers. So most carers care because they care, because they're there and because they really want to care for their loved one at a time of distress. But it invariably, or it must have an impact on their own health as well. What's so routinely is within our organisation, we try and identify carers. We try and, we see the patient, but we also wonder who's looking after them when we're not there. Who's looking after them at home, who's got that role, and we offer them specific help as well. They don't always want to take it because sometimes they feel, well, the patient's problems are the biggest ones. Why are you concentrating on me? And the answer to that is to say the patient in this case is managing because you're well enough to care, and if you weren't well enough to care, the impact on them would be negative. So I do think it's worth trying to support people to recognise their role as carers, and there is always the opportunity to have what's called a carers assessment, which focuses the conversation entirely on you rather than on the patient you're caring for, which of course is generally the focus in a clinical interaction. So and of course, as professionals, as doctors, we're often asked to be informal carers in different ways, aren't we? Or our opinions are often asked in families and communities outside our working life.
I feel like regardless of where we're going to, I am a GP at the end of the day.
Well, yes. And I think I would, I understand that. And, I didn't have, there were no doctors in my family before me. So I understand the pressures of that role. And yet I do think it's important to caution people against taking on that role to too great an extent. Apart from anything else, we're not all specialists in all areas. There's lots of things we don't know. And even in the areas where I am a specialist, a psychiatry in my case, I would not want to be offering psychiatric help or support to a family member. I would guide them, I would talk to them about it, but I wouldn't be prescriptive and I wouldn't be too dogmatic about what I thought was the right thing, because that undermines their ability to get independent care elsewhere. And the GMC, I have to say, does take quite a strict view on this in reminding us that we should act as doctors to our patients, not to our family and friends. Which doesn't mean to say you can't explain things and help them with things, but you should be really cautious about acting in the role of a doctor with family and friends.
Helen, I'm incredibly grateful for the time you've given. You have a very colourful and decorative career, and it was fantastic to, I feel, even just touch on these subjects. I feel we could go in a lot more detail, but I really appreciate you being open and honest, talking about mental health. I feel like I've had a mini therapy session, but that was part of, really going deep and asking insightful questions. But I've learned a lot today. I've got a lot to think about after, but even just thank you for sharing it for the people listening who can take that on board, interpret and take it wherever it takes them. So yeah, thank you so much for your time today. Thank you. On behalf of the Second Opinion podcast team, we will always continue to strive to further understand the mental health struggles faced by people. If you are struggling or have a loved one who is looking for support, we've put some links to mental health charities and groups such as Mind in the description. You are not alone in your struggles, and it is okay to ask for support. On this podcast, we will continue to have psychiatrists and other mental health professionals to further understand this topic, as well as ask our other guests about how they manage their mental health. Thank you for listening. See you next time.